Good morning, all you primary care providers out there. I am Dr. James Hall, and I'm a practicing nephrologist. I've been practicing for about 20 years, and we get a lot of questions from our primary care providers in town about hypertension management, chronic kidney disease management, indications for referral, proteinuria, hematuria. So, today we're going to talk about some of these things. The main thing we're going to talk about today is indicators for nephrology referral. There are probably about nine or 10 absolute indicators that if you'll see this in your lab work, in your urinalysis, your knee-jerk reflex should be refer to nephrology. And I know, it's really hard to get patients into nephrology if you're living out in rural America and you don't have good nephrology coverage. But this little short video is going to try to give you some of the indicators for nephrology referral so you'll be aware of what to do when you see these parameters. If you like what we're talking about, check our webinar below, click the link in the details. So what is the first indicator for nephrology referral? A glomerular filtration rate of less than 30 milliliters per minute. You should say, okay, this patient is in stage 4 kidney disease. This patient has to go to a nephrologist. There is no option. This patient is high risk for becoming uh, end stage kidney disease and getting on dialysis. Send this patient to nephrology. That's the first indicator. The second one is if the glomerular filtration rate is less than 60 milliliters per minute and the patient has hypertension or proteinuria, send that patient to nephrology. That patient is high risk. That patient has several risk factors that looks like they're probably going to be headed towards dialysis. And if the proteinuria is pretty high, that's an indication for a kidney biopsy. So the nephrologist will be the one determining if the patient needs a biopsy, but you will be the one determining when that patient will get to the nephrologist. The third indication is proteinuria. So urine protein, normally we excrete about 150 milligrams of protein in our urine every day. If your patient has more than 250 milligrams, that's an indication to send that patient to nephrology. Now, what happens between 150 milligrams, which is normal, and 250 milligrams, which is abnormal? That's that kind of gray area. But at the end of the day, if you check a urine protein to creatinine ratio, which is a quantitative measure of protein spilling in the urine, not the urinalysis. The urinalysis gives you qualitative, but the urine protein to creatinine ratio gives you quantitative, how much protein your patient is spilling. If you see more than 250 milligrams, that's an indicator to send to nephrology because your patient may have nephrotic syndrome, they may have glomerulonephritis, or something deeper that's causing this protein wasting. The fourth indication for nephrology referral is severe hypertension. Typically, in our patient population down in Mississippi in the United States, our patients have severe hypertension. And so, as a hypertension specialist, many of these patients get sent to nephrology, and we look for other causes or secondary causes of hypertension. Some of these could be hyperaldosteronism, renal artery stenosis, or something of that nature. But as a primary care provider, your job is mainly to recognize the patient has severe hypertension. It's difficult to manage. They're on two or three medications and it's still not controlled. That's your cue to send them to nephrology. The next indicator, the fifth thing, is hyponatremia, low sodium. If your patient has a low sodium of less than 135 milliequivalents per liter, send them to nephrology. That's another indicator that this patient needs to be seen by a specialist because there may be a medication that we're giving them that's causing the low sodium. There may be something going on in their brain. Could be a lung cancer, could be something else that's causing this low sodium. The other indicator is hyperkalemia or hypokalemia, a serum potassium of less than 3.5 or greater than 5.2 milliequivalents per liter. Both of those are indicators to send to nephrology. And from my 20 years of experience, I've noticed that a lot of times it's iatrogenic. Something that we doctors, primary care providers, are doing that's causing the patient's potassium to be low. And that's what we look at. One of the biggest things that we look at is medications. What medication your patient's on that's causing their potassium to be too high or too low. So that's a great thing that you can do before they even see nephrology. Scrutinize their medication and just see if there's something that we're doing that's causing this. The next indicator is unexplained edema. Lower extremity edema is a big common referral reason in nephrology. And the main thing we look at is medications. That's the first thing because that's the easy fix. If it's amlodipine or one of the non-dihydropyridine calcium channel blockers, those medicines sometimes can cause lower extremity edema. And so we'll stop those medications if they're causing that. Also, we'll look at heart failure, liver failure, kidney failure, obviously. But if you have a patient and you cannot get their edema control or you don't know why they have it, send them to nephrology. Next thing, unexplained metabolic acidosis. We see that a lot in our clinic. Obviously, as the GFR declines, patients cannot excrete an acid load from normal metabolism, so their serum bicarbonate levels will get lower, and that's a reason to kind of send in nephrology or do your own kind of background, kind of deciphering of what's causing this low serum bicarbonate level. If it's less than 22, that's usually our indication to send in nephrology. Next, hematuria. That indicates glomerular injury. If there's blood in the urine, usually there's something glomerular going on with the patient. Now, you can have bladder disease, such as bladder transitional cell carcinoma. You can have kidney stones, nephrolithiasis, that's causing hematuria. But honestly, if you root out bladder injury, you've ruled out kidney stones, the next reason the patient would have hematuria is probably glomerular injury, such as lupus nephritis, glomerulonephritis, or some of other type of disease that's injuring the glomeruli. That needs to be caught early and referred early because your patient can actually, be treated, and that process can be reversed if it's caught early. And finally, any other symptom that or test that you may see in the labs or in the chart that make you think, I need to get this patient to a specialist just to kind of see what they think, see what's going on with the patient, see if there's anything that I'm missing. And trust me, your patients will thank you by sending them to a specialist. I know you guys are overworked. I know you guys are underpaid. Hey, we all are underpaid in the medical field. But if you really want to be an astute clinician and you really want to help your patients and prevent them from progressing to end-stage kidney disease, have these referral indicators kind of fresh on your mind. So when you see that, you can say, send to nephrology. Well, this is the end of this video. Please comment below if there's any other things that you want us to talk about in the nephrology world. Click on the links below. We have an online course that we've created. And if you want to dive deeper into all this, click the link, check out the free webinar. We appreciate you tuning in. Thank you.